Okay, so there are so many diseases of the prostate. We cannot describe each and every disease of the prostate in just 1 hour. So we shall focus on the two main diseases of the prostate. Number one is BPH, benign prostatic hyperplasia. And number two, most important, is CA prostate. So we shall try to cover these two topics, these two main diseases of the prostate in this lecture. Okay, so let's move on. So what is our objective? What are the today's objectives? Our objective is to know what is BPH, what is benign prostatic hyperplasia, and next objective is how to approach a patient with the lower urinary tract symptoms. Why lower urinary tract symptoms? Because the patient with the benign prostatic hyperplasia will usually present with the lower urinary tract symptoms. What are these? We'll go into the depth about these and what is the treatment options for that. Okay. So let's move on. Number one is definition. BPH is a non-malignant enlargement of the prostate gland caused by the cellular hyperplasia of both glandular and stromal elements that leads to troublesome lower urinary tract symptoms in some men. So basically, it is a non-malignant enlargement of the prostate. It happens with the aging, but not all of the elderly males do have this, but it's gradually increases with age. It is one of the most common benign tumor in men, and bear in mind that it is not a precancerous condition. Okay. So let's go flashback in our first year or second year MBBS, where we have certainly read about its anatomy and physiology. A healthy human prostate is slightly larger than a walnut. Walnut means its size is about around 4 centimeter by 3 centimeter, and it's around 20 gram in weight. So weight is important because it's usually being provided to us, and its size is provided to us by the sonologist. So normal is 20 gram. And how it is surrounded? It is surrounded by the urethra below the urinary bladder and can be felt by the rectal examination. When we do put a finger inside in the rectum, then we can feel the surface of the prostate. Its relations are that posteriorly there is rectal ampulla, superiorly there is a bladder neck, and interiorly there is a pubic symphysis. Inferiorly there is a urogenital diaphragm. Its work is regulated by the androgens, which are responsible for male sex characteristics. Here you can see a different view of the same anatomy. This is the prostate, and urethra is going through it. It involves the bladder neck, and Just below the prostate, there is a membranous urethra and urogenital diaphragm. Here there is a zonal anatomy. The zones of the prostate are very important to know that peripheral zone accounts for the 70% of the young adult. Most of the patients with the CA prostate have their cancer origin from this peripheral zone. There is a central zone and there is a transitional zone. Routinely is constitutes about only 5% of the patient, 5% of the weight of the prostate. But the benign prostatic hyperplasia usually originates from this transitional zone. We'll see the zones in the next picture in the more detail. This is the transitional zone, and there is a central zone behind it and peripheral zone surrounding all over it. So remember that transitional zone is where the benign prostatic hyperplasia usually originates, and the CA prostate usually originates from the peripheral zone. So this is the prevalence of the BPH. Its prevalence increases with the age of the men. As the age grows, its prevalence increases, and at the age of 90, it's nearly 90% of the men there. So we'll now move on to the clinical side, that how are the symptoms. The symptoms, one of the lower unit tract symptoms, we'll divide it to the storage and the voiding symptoms. Storage symptoms, number one is frequency, nocturia, urgency. Why we call it storage? Because there are two functions of the bladder. One is to store the blood urine, second is to void the urine. So when the patient has to store the urine but he has frequency, then we'll call it, this is the storage symptom. And what is the definition of frequency? Frequency definition is like that: if you have to go to the washroom within 2 hours, in less than 2 hours, then it's somebody is having the high frequency. If it is in more than 2 hours, then we'll call that it's normal, it's not frequent. And nocturia, the passage of urine at the night time when somebody is asleep. So if somebody gets up from the sleep more than 2 times at night, then he is having nocturia. Urgency, when somebody feels the urge to go to the washroom, then that's urgency. Next, we'll move on to the voiding symptoms. These are the symptoms which happens during the voiding phase of the urine. So hesitancy. Hesitancy means somebody is unable to initiate the micturition. Straining is that somebody strains during the micturition. The stream gives us an idea that whether it is a good stream or slow stream, and intermittency is clear by its word, and feeling of incomplete bladder emptying. There is a long list of void investigations, but we have cut short because during the benign prostatic hyperplasia, only ultrasound and urine ER is enough. So what will you see during the ultrasound? The size of the prostate, how bigger the prostate has become. Normal is 20 gram. If somebody is having 30 gram, 40 gram, then it's benign prostatic hyperplasia. And whether there is what about the pre-void and post-void volume of the urine? If somebody is retaining the urine inside the bladder, then probably he's unable to empty the bladder completely. And he's also having the bilateral hydronephrosis. It means that the urine he's retaining in the bladder is also going back to the kidneys. So definitely this patient is going to be in the renal failure because of this hydronephrosis. So how will we diagnose it? Number one is careful history and physical examination, including DRE, digital rectal examination. Digital rectal examination is very important for the diagnosis of the prostate disease. However, you cannot assess the proper size on the DRE because it really underestimates the size of the prostate. But it is very important because it gives you a clue that whether the surface is smooth or there is an nodule over there, or it's irregular. If it is irregular, then it's probably there is a prostate cancer. This is IPSS, International Prostate Symptom Score. This is usually being done by filled by the patient inside over OPD. If the patient is literate enough to read each and every instruction, then he can probably fill this form, and by this IPSS we can do the assess whether the patient is having mild symptoms or moderate symptoms or the severe symptoms. It depends on the severity. If he is having more frequency, intermittency, weak stream, straining, or nocturia, then his symptoms will be more severe. So now we'll move on to the differential diagnosis. Differential diagnosis, there are prostatic as well as non-prostatic. Non-prostatic includes urethral stricture, bladder neck contracture, bladder tumors, neurogenic bladder calculi, and urinary tract infections. And the prostatic are prostatus, prostatic cancer. What are the treatment options? There are multiple, so many. It always starts with the lifestyle modification. Lifestyle modifications will be to reduce the caffeine intake or water intake, reduce the weight. Number two is watchful waiting. If he is having the mild symptoms, we can ask that just watch over and don't do anything. If somebody is having moderate symptoms, then we can go for the medical therapy. Or if somebody is having the severe symptoms, then we can go for the surgical treatment. So what are the management goals? Number one is decrease the bladder outlet obstruction, improve the bladder emptying, improve the symptoms, lower the detrusor instability, and if there is an renal insufficiency, it's to prevent it deteriorating. Prevent future episodes of gross hematuria, UTI, urinary tract retention, quality of life and sexuality. and the management very much depends on the severity of the symptoms. So now we'll move on to the medical therapy. Medical therapy, it's always starts with the alpha adrenergic blockers or 5-alpha-fructose inhibitors or plant extracts or combination of all of these. What is the mechanism of action of these drugs? There are so many receptors inside the bladder and the bladder neck and the prostatic area. The alpha receptors are mostly present at the bladder neck and at the prostatic area. And the muscarinic receptors are present in the bladder overall. So this is the main bluish dot you must be seeing over there. These indicate the alpha receptors. Distribution of alpha 1 adrenergic receptors in the lower urinary tract and site of action of alpha 1 adrenergic receptor blockers. Selective agents target receptors predominantly localized to the bladder and prostate. Non-selective agents may have more symptoms. Medical management will continue. This is just a short list of what are the drugs we have for that. There are long-acting drugs like terazosin. It commonly comes with the name of Hytrin and with the dosage of 1 milligram, 2 milligram, and 5 milligrams. And it's very cheap. It costs around 221 rupees for 1 milligram. But the issue is that this drug causes postural hypotension. Why postural hypotension? Because the alpha receptors are not only present on the bladder neck, they are also present at the arterioles all over the body. So if they cause dilatation of the arterioles, then when somebody gets up from the chair or his bed, then suddenly his blood pressure drops because they are not being vasoconstricted. It's continued. The other drug is very important, that is doxorubicin. It comes with the dosage of 2 milligram and 4 milligram, and it costs around 341 rupees. Other number 3 drug is alfuzosin, that comes with the name of Zetrol. All these have the same type of side effect, postural hypotension. So we have a solution for that we usually ask the patient to get this drug at the time just before sleep, just before going to the bed. If somebody takes it before sleep and he lie down on the bed, does not get up from the bed, then probably he will not have this postural hypotension. Alpha 1A selective drug. This is one of the very important newer drug, because it's alpha 1A selective. Alpha 1A receptors are only present at the bladder neck. They are not present in the arterioles. So it does not have so much side effects like postural hypotension and other. Its name is tamsulosin, but it costs around 35 to 40 rupees. And it's a single drug, single dosage drug one has to take before sleep, and it comes in the 0.4 milligram dosage. So our medical treatment is moving on from alpha receptors to 5-alpha reductase inhibitors. Why 5-alpha reductase inhibitors? 5-alpha reductase inhibitors are very important in this sense that they reduce the size of the prostate. The alpha receptor, alpha adrenergic blockers we have discussed just now, they just improve the flow of the urine. They does not reduce the size of the prostate. So patient usually asks us that how much time I has to take these drugs. So if we tell them that you have to take this drug for the whole life, then they usually ask that how much, why this drug is not reducing the size. So if we want to reduce the size of the prostate, then we have to move to the 5-alpha reductase inhibitors. So 5-alpha reductase inhibitors inhibit the conversion of testosterone to dihydrotestosterone, the more potent androgen in the prostate. This causes shrinkage of the prostatic epithelium and therefore a reduction in the prostatic volume. So these are the most common drugs being prescribed. You should know their names and their dosage as well. So that's why I have included these. Number one is finasteride, and the most common name is Proscar, 5 milligram. It costs around 675 rupees. And other drug is dutasteride, and it's 0.45 milligram, and it costs around 2000 rupees. So one of the most important thing is that they does not affect the symptoms early. The size will reduce in a year or 2 year time. So if we prescribe them only this drug like finasteride or dutasteride, then the problem is that patient does not improve the symptoms. He has to wait for a year or two. So the solution to that is combination. If you give them tamsulosin to improve their symptoms at this time and dutasteride for the long run time to reduce the size of the prostate, then this becomes a good combination, but the cost increase. The combination most important drug is Dudot. It reduces the size of the prostate and also improves the symptoms. Sometimes, not every time, we prescribe them anti-cholinergics. Anti-cholinergics are prescribed when somebody is having urgency. He cannot stop his urine, then we prescribe them this. There is a long list of anticholinergics available in the market. These are the oxybutynin, tolterodine, tropsium, flavocosate, and solifenacin. So now we'll move to the medical treatment to the surgical treatment. And it's very important to know that when it is absolute option to go for the surgery, it means there is no other option but surgery. If you go for the medical treatment, the things will deteriorate with the time. There are absolute indications for surgery. Number one is upper tract affected. Upper tract means kidneys are affected. If somebody is having the reflux of the urine, then there is no option but to go for surgery. If somebody has developed the bladder stone secondary to the enlarged prostate, then you will also, then there is also no option but to go for surgery. If somebody is having gross hematuria secondary to the prostate, not other issues, then it's best to go for surgery. If somebody is having recurrent urinary retention, then he should go for surgery. And somebody who failed to respond to the medical treatment, then, so these are the most important 5 absolute indications for surgery. So what are the surgical options? We have so many surgical options. One is endoscopic. Endoscopic is transurethral resection of the prostate. That is TURP. That is the gold standard for this prostate. And other is open prostatectomy, and minimally invasive is transurethral resection, transurethral needle ablation, TUNA, transurethral microwave therapy, transurethral electrovaporization of the prostate. But remember these minimally invasive options are only being done for the patients with the high risk for the GA. When we cannot go for general anesthesia or regional anesthesia for these patients, then we go for these options. Otherwise, TURP is the gold standard. This is just one picture showing the TURP. You can see there is an endoscope going from the urethra into the bladder, and its tip is having a loop. This loop is cutting the prostate in the form of chips, and chips are being collected in the bladder. And at the end of the procedure, we really wash out all these chips out of the bladder. So this is the gold standard. If you want to see this TURP, then after the lockdown, please come in our theaters. You can watch it. Other option is open prostatectomy. Open prostatectomy, also there are 2 approaches. One is retropubic approach and other is suprapubic approach. So these are not being done nowadays very frequently. We really do them only when there is a huge prostate and it will be impossible to remove it completely via TURP. Then we go for it. Oh, so this is the conventional surgical treatment, and it's being done when prostate is more than 100 ml or 100 gram, or the patient is having something like that, big bladder stone or diverticulum. Then we go for this open prostatectomy. So we'll briefly reinitiate how to approach these patients. We'll start our initial diagnosis by taking careful history, doing digital rectal examination, urine analysis or serum PSA, and assess how much the patient is bothered by these symptoms. If the patient is having the mild symptoms, then it's better to go for only watchful waiting. If patient is having moderate symptoms, then we discuss the patient the options of treatment. Number one, medical treatment, other true, is surgical treatment. But we have to evaluate if somebody is having refractory acute urinary retention, gross hematuria, bladder stone, recurrent UTIs, or renal insufficiency, then there is no other option but surgical treatment. So this is the summary so that you people can remember what we have taught this in this last half an hour. BPH, benign prostatic hyperplasia, becomes increasingly common as men age. Many men with BPH are asymptomatic or have only mild symptoms and may not require therapy. Men who develop upper or lower urinary tract injury will require surgery. Alpha adrenergic antagonists provide immediate therapeutic benefits and are first-line treatment for smaller prostates. Five alpha reductase inhibitors require long-term treatment for efficiency and are beneficial for larger prostates with the mild to moderate symptoms. So summary is continued. Combined alpha-adrenergic antagonists and 5-alpha reductase inhibitors therapy appear to be superior to either agent alone for long-term treatment. The choice of the medical treatment may be made on the basis of the cost and side effects profile of the drug. TURP is the gold standard for men who require an invasive procedure and are in good health. Men that are poor candidates of surgery and require an invasive procedure should be advised on tuna. Other surgical therapies may be reasonable option based on the local expertise available and instruments available. So we have finished benign prostatic hyperplasia. Now we'll move on to the CA prostate. So as I told you at the start, we'll focus on two main diseases of the prostate. One is benign prostatic hyperplasia and other is CA prostate, because these are the most common diseases of the prostate. Etiology. Family history is very important. 2 to 3-fold increased risk in men with the first degree relatives. Early onset of disease and Mendelian autosomal dominant inheritance accounting for less than 10% of all cases, but 40% in younger men in less than 55 years. This is an hereditary association. Racial factors, there is a striking difference in incidence and mortality between the black and white population, more common in blacks. Environmental factors can be seen, but there is no clear-cut identification. It's more common in the Western countries, but as Asians migrate to the USA, they also have higher incidence of prostate cancer. So probably the diet they usually take over there make them more prone to this disease. So we'll move on from etiology to the pathology. The most common cancer is adenocarcinoma. 95% of the prostate cancers are adenocarcinoma. Rarely there are other type of carcinomas like small cell, mucinous, endometrioid, transitional cell, squamous cell, basal cell. So please remember adenocarcinoma. So this is a very busy slide, but it's very important. Clinical manifestations. Clinical manifestations depend on how much the cancer has advanced. If somebody is having this cancer as an early stage, then probably he will be asymptomatic. If somebody is having disease at the locally advanced stage, then probably he will be having obstructive symptoms, hesitancy, intermittency, decreased force of urine. He might be having retention of urine, hematuria, hematospermia. The next important is somebody is having advanced disease. Then probably he will have edema of the lower extremities, pelvic and perineal discomfort, metastatic. If somebody is having metastatic disease, then probably his bones are involved. He will have bone pain, spinal cord compression symptoms, and paraparesis. He might have hematuria, hematospermia. So rectal involvement may cause hematochezia, constipation, intermittent diarrhea, abdominal pelvic pain, renal impairment due to the prolonged bladder outlet obstruction or fluid or electrolyte imbalance. If somebody is having involvement of the neurovascular bundles, then he might have impotence, pelvic pain, priapism. Advanced disease will have bony pain, pathological fractures, spinal tenderness. So it's a wide spectrum. Depends on the stage, on which stage the patient is coming to your clinic. If it is an early stage, then the symptoms will be less. If it is at the little bit advanced stage, then he will have the low unit tract symptoms. If somebody is having metastatic disease, then his symptoms will probably be much more. So now we'll move on to the diagnostic workup. The most important thing to do for this is PSA, prostate specific antigen. This will give you an idea that how much there are the chances of CA prostate. Remember that PSA increases in other diseases as well, but most common reason is CA prostate. So radiological investigations will do transrectal ultrasonography and biopsy of the prostate via transrectal or perineal, chest radiographs, CT scan and MRI, and PET scan sometimes. So how will we diagnose it? The number one is history. History is very important. And other is abnormal DRE. What is abnormal DRE? If you'll do DRE, then you'll feel nodular hard prostate in the C prostate. But in the BPH, you will feel smooth large prostate. And his PSA will be usually raised. It will be more than 4 nanogram per ml. We can do trust guided biopsy to establish the diagnosis and to report and the extent and grade of cancer in each cohort. Imaging starts with the chest X-ray, pulmonary metastasis to see the pulmonary metastasis or miliary pattern. We can do skeletal survey and ultrasound abdomen to see is there any hydronephrosis, large post-void residual urine volume, retroperitoneal lymphadenopathy, or any liver mets. We usually do CT scan of the pelvis to see this determination size of the prostate, exact size, and assess the pelvic lymph nodes for the metastasis so that we can plan the treatment accordingly and see any extra prostatic extension and lymph node involvement. MRI is more superior than the CT. It will provide more contrast between water density structures like prostate, seminal vesicles, fat, perivesical tissues. In CA prostate, you will see a focal peripheral region of decreased signal intensity surrounded by a normal peripheral zone. Bone scan is important. It gives us clue that whether this disease has progressed or metastasized to the bones. Remember that number one metastatic site of the prostate is to the bones. If somebody comes in your clinic with raised serum PSA and lower urinary tract symptoms, then go for the first option will be to go for the bone scan. If bone scan is negative, then we will go for the MRI. So if somebody is having the bony mets, then you will see these blackish dots you can see on the picture in their different bony parts. If you can see that there are different black dots in their bone parts, this shows osteoblastic activity over there. So we'll move on to another important thing for the CA prostate. This is Gleason score. I'll take you back to the patient. That is, if somebody is having raised PSA, then we'll do transrectal ultrasound, and we suspect that there is an CA prostate. Then we'll do trust guided biopsy, and will send these scores to the histopathologist. Then histopathologist will look at the slides just like we are seeing on our screen, and he will determine according to the arrangement what is the Gleason score. So Gleason score basically indicates that the histopathologist will tell you that whether this is well differentiated or moderately differentiated or poorly differentiated cancer. So this is the brief picture showing you that small uniform glands means well differentiated, more stroma between glands than Gleason 2. If it distinctly infiltrates margins, then it's Gleason 3. And if there are irregular masses of neoplastic glands, then it's Gleason 4. And if there is an only occasional gland formation, then it's Gleason 5. So if the Gleason is 5, then it's probably poorly differentiated. So this is basically a histopathological grading of the cancer. This is the clinical staging of the prostate cancer. As you must have read about the TNM staging for all other cancers, as the staging is important for every cancer. So we'll discuss now what is the tumor grade, what is the lymph node grade, and the distant metas. So TNM, tumor, lymph node, and mets. Okay. If T0, then there is no evidence of primary tumor. If T1, then non-palpable tumor that is not evident from radiological imaging. T2 means palpable tumor confined to the prostate. T3 means palpable tumor extending beyond the prostate. T4 means palpable tumor that is fixed or that invades adjacent structures. So T2 is basically locally confined, and T3 is extend beyond the prostate, and T4 that invades the surrounding structures. So lymph nodes, if less than 2 centimeter, then it's N1, and if it is less than 5 centimeter, then it's N2, and if it is more than 5 centimeters, then it's N3. And if there are mets, then it's probably N1. So from stage 1 is locally advanced confined cancer. Stage 1 and 2, and stage 3 is locally advanced, spread to the surrounding structures like seminal vesicles. And stage 4 is advanced, spread to the bladder, rectum, and spine. Treatment. So before moving on to the treatment in detail, we have to know that there is in staging, there is a PSA and there is a Gleason score. All these three things will tell you that whether the patient is low risk group or in the intermediate risk group or high risk group. So we have to divide these patients into these risk groups. If somebody is having stage T1 and PSA less than 10 and glycerin score less than 6, then probably he's in the low risk group. If somebody is having the T2 and PSA between 10 to 20 and glycerin score around 7, then probably is in the intermediate risk. And if somebody is having T2C or T3 or more than that, or initial PSA more than 20 and glycerin score 8 to 10, then probably is in the high risk group. So according to these risk groups, we'll decide about the treatment options, because there are so many treatment options like radical radiotherapy, radical prostatectomy, cryoablation, or hormonal therapy. This is the same risk group we discussed in the previous slide. Low risk group, intermediate risk group, high risk group, very high risk group, and metastatic. So there are so many options for treatment. Number one is radical prostatectomy. We usually do radical prostatectomy in the localized cancers and in the locally advanced cancers, in the low risk group or intermediate risk group. Advantages are that it completely removes the prostate. Again, there are so many options that how to do surgery for that radical prostatectomy. One is open option, other is laparoscopic, and the most advanced is robotic surgery for that. If somebody is not fit enough to go for this big surgery, then we can go for the radiotherapy. Radiotherapy can be done with the different techniques like conventional 3D CRT, IMRT, proton therapy, brachytherapy. If somebody is having the metastatic cancer, then what are the treatment options? Then the treatment options becomes reduced, because the cancer has already spread from the prostate to the local areas to the bones and other organs probably. So we don't have much options. So most important is the hormonal therapy, because this cancer is dependent on the androgens like testosterone for the growth. If we stop the testosterone production in medical form or in a surgical way, then we can probably reduce the impact of this cancer. We cannot completely stop it, but we can reduce it. So surgical way is to do orchidectomy, and medical ways inhibition of LHRH or LH. There are so many drugs written over there: leuprolide, cosrelin, triptolin, hystrelin. You don't need to remember all these drugs, but you should know that this cancer is androgen dependent or hormone dependent. So we have the options of giving them these, but these are given in only the setting of metastatic cancers. Inhibition of androgen senses can be done with the other options like aminoglyceride, voriconazole, and anti-androgens like flutamide, biclutamide, naltrexone. Thank you. How can we appreciate on DRE whether it's prostatitis, BPH, or adenocarcinoma? So that's a very good question. We'll do DRE and palpate the prostate. If we'll palpate, if there is a smooth, non-tender prostate, then probably it's benign prostatic hyperplasia. And if it is tender, boggy, you'll feel something boggy, then it's probably prostatitis. And if there is a cancer, then you will feel probably hard nodular prostate. I think the answer to your question is now clear. If there is any other question, you can ask. Caffeine, she has asked that what does the caffeine has on urinary output? Caffeine does not have effect on the urinary output, but it does have effect on the bladder emptying. If somebody takes large quantity of caffeine, then it probably irritates the bladder mucosa. Then he will need to go to washroom again and again. So he will have urinary frequency and nocturia. Sakina Mansoor has asked that what is the association of diet with the prostatic carcinoma? Well, there are certain things mentioned in the books, but there is no clear-cut evidence for that. It has been believed that these westernized diet, which are more of the time of junk food, they usually have these people have more prostate cancer. So that's why we thought that probably that's the one of the reason they have increased chances of prostate cancer. There is no clear-cut evidence that this diet caused prostate cancer or other diet caused prostate cancer. Any other question you people can ask? We are cut short of time. There is a question that said TURP, we are removing the prostate in chunks in the bladder. Want that rupture the urethra because prostate is around the urethra, right? Yes, you are right. Because the prostatic urethra is covered by the urothelium. When we cut the prostate, we also cut the urothelium. But the urothelium is an endothelium. After 1 to 2 days, urothelium will regrow over the prostate. So we have no issue with this endothelium. Thank you very much.